to all everybody here and to all our presenters to this press conference, and it's about scaling up HIV treatment in the developing world. My name's Anton Pozniak, and I'm the HIV Service Director at the Chelsea and Westminster Hospital in London, and I'm also, until Friday, the Treasurer of the International AIDS Society. So firstly, I'm just going to set the scene, and then after that we're going to have some remarks from each of the researchers, and then we're going to get about half of the time left over, which we'll have left over for your comments. Now, it's been live streamed on the International AIDS Conference YouTube channel, and then will be archived for future viewing. So, being a British guy, I have to keep my language very careful. Now, I'd just like to make a few points. A lot of this is around the fact that UNAIDS set a community challenge of achieving the 90-90-90 target. And I think all of you know what that is: 90% knowing their status, 90% having access, and 90% achieving viral suppression. And then their recent report shows that actually it's gone to 57, 46, 38, which is a little disappointing from everybody's point of view. The next issue really to say is why is that prevention and treatment are really very much linked, and we really need to try and shrink the epidemic using different things. We know that antiretroviral therapy is effective and also is a form of HIV prevention, but how can we make things better? So we have to look at other ways of preventing HIV, and we need to renew again our efforts so that our early gains in the recent past can be carried forward. So we need some evidence about test and treat in 90-90-90, and we need to get some insights in what we have to do next to try and ensure that we can get control of the epidemic. And we also now, because of what we're going to address is where the best practice comes out of the test and treat programs and where things haven't worked so well, and what can we do to fix that and make it better. So these are the topics to be addressed by our panel members today, through the research studies, all by wide experience. And we're going to have a comment by Sharon and Lynch at the end about bringing the experience of MSF about the priorities about scaling up treatment. But the first two discussion points are going to be about two big programs which have got different outcomes. So it's a great pleasure to introduce Mayer Peterson, who's from University of California, Berkeley, who's been involved with the SEARCH study, which is a test and treat access study in Uganda and Kenya. Mayer, can you just outline what the study showed?
Absolutely, thanks so much. So as we've seen at this conference, one of the big questions is how do we get to 90-90-90? We're tackling that in an ongoing cluster randomized test and treat trial in rural Uganda and Kenya called SEARCH. In the intervention arm of SEARCH, we test people at health fairs, and we have a new model of care. It's very patient-centered. One of the unique features of SEARCH is that we're delivering HIV care as part of multi-disease care. What my presentation is about is how close we came to achieving the UNAIDS 90-90-90 target with our intervention. We had about 78,000 stable adult residents of the communities receiving the SEARCH intervention. Of these, about 7,000 were HIV positive. We looked at how well we were doing in terms of diagnosing, treating, and suppressing this population. With the SEARCH intervention, we hit or exceeded all three UNAIDS targets after 2 years. Part of the 90-90-90 goal is population viral suppression. So in other words, among all HIV positive people, how many have a suppressed viral load? This is important because viral load is a major driver of HIV transmission. We found before the study started that less than half of all HIV positive people were virally suppressed. After 2 years of receiving the intervention, over 80% were suppressed, above the UNAIDS target. We also looked at some subgroups. Before the study, we were doing worse with suppressing both men and youth. While we were able to reduce the gap in testing, treatment, and suppression in these groups, disparities remain, particularly among the youth, where we achieved only 66% suppression. Next year, we will compare new HIV infections and other health, economic, and educational outcomes between these intervention communities and the control communities in our study who received country standard of care. And we should then be able to evaluate the impact of reaching UNAIDS target on these outcomes. Thank you.
Now to Francois Davy, who is a professor of epidemiology in Bordeaux, and their group has performed a study in rural communities known as TAFS trial, and I think the results of that are slightly different to what we've heard from Maya. Thank you very much indeed, Francois.
Thank you, Anton, and good afternoon, everybody. So my presentation, I'm Francois Davies. My presentation on the TAFS trial will be on Friday, but we have a press release that is available for you today. So the study we conducted was in South Africa, in rural South Africa, and we did a question, and what we do today is we report for the first time what is the effect of universal test and treat, what I call UTT, at the population level in terms of reduction in HIV transmission. So I don't elaborate on why we did the study, we can answer that later on, but what we decided to do is work in a very, very affected community, rural, about 2.5 hours north of here. This is very poor, very rural, very low employment rate, but HIV services exist and have been progressively expanded there. So we selected 22 communities, about 1,200 people each. And on the top of the regular preventive services, we went home every 6 months to provide HIV testing to all households. And in half of these 22 communities, these clusters, we proposed those who were positives to be treated immediately, irrespective of their clinical or immunological staging. In the 11 other communities, the other randomization, we kept the South African relatively restricted guidelines. We also set up outreach clinics so that for 80 people in this area, they didn't need to travel or to walk more than 45 minutes to get HIV services. And during the home rounds, we collected dry blood specimens so that we could repeatedly obtain data on new infections that could occur in this population. And we just completed the study 4 weeks ago. So what have we learned? So first of all, this population is rural but highly mobile. So about a quarter of those we expected to find in the homes, especially young men, were not available and could never be reached. But the good news is that for everybody we found in the homes, the high level of acceptance was extremely high. It was almost 90% of those who were at home accepted to be tested. We found that the prevalence was really very, very high, as expected. Unfortunately, 34% of those living in this area were living with HIV, and about a third of them at the beginning of the trial were already on ART, which means that there was already some provision of services. For the others for which we offered the services, we have to say that the entry into care was slow, and we didn't reach the anticipated targets during the trial period. So by the end of the study, which was just a few weeks ago, the gain in ART coverage was only 9.4% in the intervention group, in which we proposed treatment to everybody, and 1.8% in the control group. The final good news is that 95% of those who were on ART had a perfect viral suppression at 12 months in both arms. So now the important results in this large population, we identified 495 new infections in the course of these trials. This is very high rate. But unfortunately, the incidence, the acquisition of infection remained quite comparable between the two arms. 2.13 new cases per 100 person years of follow-up in this intervention arm to 1.3, and 2.27 in the control arm. So needless to say that this is statistically not significant. So we were not able to demonstrate that at the population level, a UTT strategy, a universal test and treat strategy, was rapidly able to decrease transmission. But I want to be clear that the UTT strategy should not be revisited or criticized in the light of these trial findings. And particularly, I would like to stress that the South African authorities have recently decided study to embark into a UTT national policy starting in September of this year, and this is the right decision, and this should be strongly supported. So what we show here, and maybe are not confirmed by other studies like Maya early results, maybe that they are testing everybody is very achievable, but that it does not immediately translate everywhere into ART initiation and thus in measurable reduction in transmission. So there are many barriers that we are facing: contextual, organizational, behavioral, gender and age specific probably, to optimal linkage and full use of ART by the general HIV population, at least in this rural part of South Africa. Be happy to answer questions.
Thanks, Francois, and it leads us really well into the next speaker, Professor Wafa El-Sadra, who's head of CIDR at the Melbourne School of Public Health in Colombia, and she was involved in the Link for Health, which sets out to find ways to plug some of the leaks in the treatment cascade in Swaziland, and I'd be very grateful if you could describe how you did that. Thanks.
Okay, thank you very much, and it's a great pleasure to present the findings from the Link for Health study, which was conducted by ICAP at Columbia University in collaboration with the Ministry of Health in the Kingdom of Swaziland. And I want to acknowledge the presence of Dr. Velepi Okello. I think I see her in this blinding light, who's the Deputy Director at the Ministry of Health, and without whose support the study would not have been possible. So as we're all well aware, there's a severe epidemic in Swaziland, but also that there's a robust response to the epidemic by the Ministry of Health. We also recognize there are multiple gaps in the HIV care continuum, and that these gaps require interventions that are structural, behavioral, as well as biomedical. Thus far, most studies that have tried to address the gaps in the cascade have focused on one step, either on testing or on linkage or viral suppression or retention. However, with Link for Health, we aim to assess a combination of interventions, a whole strategy, combination intervention strategy that is aimed at multiple parts of the cascade. So the design of the study was as follows. It was a cluster randomized study conducted in Swaziland with 10 study units. Each of these consists of a secondary health facility and affiliated primary health facility, and these 10 study units were randomized to the intervention or to the standard of care. And at these sites, HIV positive individuals, adults who were ART naive, were enrolled in the study. Now, what was the combination intervention strategy? It consisted of 5 different interventions, as I mentioned, each targeting a different step in the cascade. First of all, point of care the CD4 testing at intervention sites, accelerated ART initiation, use of SMS for linkage and retention reminders, provision of a basic prevention and care package, and lastly, a non-cash financial incentives for linkage and for retention. The primary outcome was to compare the combination intervention arms or the sites to the standard of care in terms of the primary outcome of a combination of linkage to care at 1 month after a positive test plus retention at 12 months. So here are the results. There were 2,200 participants that were enrolled in the study. 60% of them were women and 20% were less than 25 years of age. These participants were followed for 12 months, and this research was integrated in the usual care. This was a pragmatic study, and the outcome was also assessed utilizing routinely collected data. What we found was that participants at sites that were randomized to the intervention, the combination intervention, were significantly more likely to link at 1 month plus be retained at 12 months. The relative risk was 1.48, meaning that 50% higher, they were 50% more likely to be linked plus retained at 12 months. In addition, we also looked at other secondary outcomes. Similarly, in the intervention, participants who were at the intervention sites, they were more likely to link alone. They were at any time, they were more likely to be retained at 12 months. In addition, the time to ART initiation was shorter, significantly shorter, and also the assessment for ART initiation was also more likely to occur. And finally, death in the pre-ART period was also significantly less likely at the intervention sites. So the study demonstrated that this intervention, this package of interventions, was highly effective in terms of linkage and retention of HIV-positive adults in the Kingdom of Swaziland. We also found that it was highly effective in terms of several secondary endpoints. And lastly, also, it's a pragmatic study. These are pragmatic interventions, and we believe that such packages of interventions can be easily adapted and adopted for other populations and in other settings. Lastly, there are ongoing analyses. We're looking at cost effectiveness of the intervention, of the package, of the strategy itself. We're also going to be looking at viral suppression. And lastly, we also did some qualitative assessments to determine the acceptability of this intervention by both the providers as well as the participants. And lastly, the study will be presented in the session to follow this press conference at 2:30 by Molly McNary, right there, sitting up front. And the study was funded by the NIH and supported by PEPFAR. Thank you.
Thank you so much, Wafa. We move now on to a subject that was tackled in the plenaries this morning regarding two plenaries around young people and adolescents. A great pleasure to introduce Dr. Mayuri Maskew, Senior Researcher in the Health Economics and Epidemiological Research Office at the University of Witwatersrand in Joburg, and she's been establishing the size of the population of adolescents who are receiving antiretroviral therapy in South Africa and looked at treatment outcomes of this group, many of whom have been taking antiretrovirals for many years. Thank you, Mayuri.
Good afternoon. So this week I've had the opportunity to present data from the NHLS National HIV Cohort and describing the youth treatment bulge that we're seeing occurring in South Africa. And I think there's some logical expectation that the numbers of adolescents on ART will increase over time. And this is due to two processes. So of course we've got survival of perinatally infected children on ART, and they're now aging into adolescence. But then of course we also have new horizontal infections occurring during adolescence that are adding to these numbers. But despite this awareness and the fact that adolescents have been identified many times as a key population for health systems planning, in South Africa until now there has been no nationally representative cohort available for us to quantify these increases that we might be expecting and to inform policymakers around this. So recently our group has been working with the team at the National Health Laboratory Service in South Africa to develop a national HIV cohort. And the way we've been doing this is by using routinely collected laboratory data to impute key points in a patient's clinical care program. For the current analysis that I've been presenting here, we analyzed CD4 count and viral load data from patients aged 20 years or younger at the date of testing. And we did this for the period 2004 until 2014. And this included a little over 1 million patients. So we defined being on ART as having at least one viral load result in the NHLS database. And then what we did was we compared the distribution of age amongst those on ART by calendar year. And what emerged is this demographic bulge of HIV-infected adolescents on ART that is occurring over time. So what you see is a shift in the relative distribution of those on ART away from those under 5 years of age and towards those over 10 years of age. And there are two parts to this shift that are worth noting. First, we're seeing an increase in the absolute numbers on ART, a sort of upward shift, if you like, of the curve. And this confirms for us that the treatment program is expanding over time and those that are infected are getting onto treatment, presumably in childhood. But secondly, we're seeing a right shift of the curve as perinatally infected children survive into adolescence. And on top of that, we have new horizontal infections occurring in the older adolescent groups that are continually adding to the upshift. There are two other points about the 15 to 19-year-old group that I think are worth highlighting. So first, not only are the numbers on ART increasing, but also this group experiences disproportionately poor treatment outcomes compared to other age categories. We found that only 62% of those aged 15 to 19 years currently in care were virally suppressed. And this was compared to 74% in the 5 to 9 year age group. The second point I wanted to make was about the gender distribution of those currently entering into care. So the distribution is roughly equal between boys and girls in the younger age groups, as you would expect to see from a perinatally infected population. However, when we look at the group above 15 years, we see the distribution shift predominantly to females. And what we found was that more than 80% of those who were aged 15 to 19 entering care in 2014 were female. So this is in keeping with what we know of the patterns of horizontal transmission in young people, but I do think that it highlights the plight of young women and the urgent need to intervene in reducing their risk of acquiring an HIV transmission during the key adolescent period. So I think that our findings have some important, I think it provides an important data point for policymakers when considering planning for adolescent programs. Because the other point to consider is that if we project forward a couple of years from now to 2019, the peak that we're currently seeing in the 10 to 15-year group will have shifted to the 15 to 20-year-old group, and the numbers will be even higher than what we are seeing now. And on top of that, we have the burden of this population experiencing disproportionately poor outcomes. So for us, those points are really worth thinking about at the national level. Thank you.
Thank you so much. We now move on to Professor James Hakim, who's Professor of Medicine at the University of Zimbabwe, and his research team has performed the REALITY trial. I think there's 2 late breakers on Friday from REALITY, so please don't miss that. And it really asked whether or not it was possible to reduce mortality among those who access antiretroviral therapy at a really advanced stage of infection. Could we do more, or are the high death rates inevitable? James.
Thank you, Anton, and good afternoon. I'll share with you results of the REALITY trial, and we'll be presenting 2 late breakers on Friday. We are obviously very excited about the increasing number of patients who are being put on antiretroviral therapy. But there are a number of important differences between outcomes in patients who are put on antiretroviral therapy in resource-rich countries and resource-limited countries. One of those outcomes is early mortality, especially mortality at 6 months. And what has been noted is that mortality at 6 months could be anywhere from 6 to even 10 times more in patients who have been initiated on antiretroviral therapy in resource-limited settings. And there are several reasons for this. One, most of the patients that we initiate on antiretroviral therapy are severely immunocompromised with very low CD4 counts. And there are a number of other intercurrent conditions which are important in resource-limited settings, like tuberculosis, cryptococcal disease, bacterial infections, and there is also a tendency to have patients who are severely malnourished initiating therapy. And that could be the reason why there is this high mortality. So we then designed a study that was conducted in Uganda, Malawi, Kenya, and Zimbabwe to look at various interventions. So we proposed 3 interventions. One was to give an additional antiretroviral drug, raltegravir, to the 3 combined antiretroviral drugs that we normally start patients on in the initial 3 months to see if this will reduce mortality in the first 6 months of therapy. The second randomization was to give a package of preventive prophylaxis, and this included cotrimoxazole, which is given to everybody, but we included this in the suite, isoniazid against tuberculosis, azithromycin, this is an antibacterial for sepsis, and fluconazole as an antifungal agent. And the third randomization was to give supplementary ready-to-use feeding. So the two presentations on Friday will be on the additional raltegravir and the enhanced prophylaxis. The enhanced prophylaxis study was positive in the sense that when we gave a combination of prophylactic agents, the mortality at 6 months was reduced by 25%. That means if you treat 100 patients, you achieved a reduction of mortality of 3.3 patients, which is extremely positive. And we also noted that the rate of adverse events because of the increased medication that you're giving patients was not increased. Similarly, there was really no interaction, no significant interaction between the prophylactic agents that we gave and the antiretroviral drugs. So we'll respond to any questions.
Thank you very much indeed, James. And now it's with an immense pleasure to introduce Ms. Sharon Lynch, who's the HIV and TB Policy Advisor for the Doctors Without Borders Access Campaign, and she brings the wide experience of MSF to bear in considering what the priorities should be for scaling up treatments in the developing world. Thank you so much.
Thank you. So I'd like to give you a bit of our data that we've been sharing at this conference. Each illustrates the fact that not only is 90-90-90 feasible, but it's needed urgently. So in KZN is in a routine program setting, but where we did introduce early treatment at CD4 500 initiation, we have the following cascade results. So 75% of people living with HIV know their status, 85% of whom are on treatment, 86% of whom have maintained viral suppression. So very close to the cascade. I really appreciate everyone's data here in terms of what's showing what's possible. That's in Utungulu. Now it's important to know that in Utungulu, just like in KZN, we can never just talk about bending the HIV curves. We should never just talk about treatment in terms of reducing HIV incidence when you have in this province such high HIV-TB co-infection. When in South Africa, if you haven't heard Minister Motsoaledi say it enough, 80% of deaths among people living with HIV is TB, driven by TB. So we know that ART can prevent TB, development of TB disease by 65%. So we know we can bend that TB curve as well. So the other bit of data I would like to share with you is from Swaziland. So with government, we implemented Test and Start. Among people who started treatment, 87% of whom, 87% were newly diagnosed with HIV. This doesn't mean that everyone was walking well, but a majority were. 97% of people who were started on treatment remain virally suppressed at 6 months, and we'll continue to come back with data. Now, I'd also like to tell you that among people who were the walking well, so CD4 over 500, let's say, so CD4 over 500 had the same adherence, if not better, frankly, than people who had CD4 under 500. So we should never question again whether it's true that asymptomatic patients can stay on treatment. Of course, it would help if we were to bring in the better ARVs, such as dolutegravir, so they don't have to face side effects. And so here we are, we're giving people that we can reach at the community level, those that present at the clinic, the best chance at survival. And yet there's this other reality. So in West and Central Africa, only 1 out of 4 people have access to treatment. 1 out of 4 AIDS deaths worldwide are in West and Central Africa. 1/3 of the people that are needed to be on treatment in order to reach this 30 million people by treatment by 2020 are in West and Central Africa. So those are the big numbers, but let's bring it down to the hospital. So in Kinshasa, where we work, and this is a so-called low prevalence country, 86% of the deaths in hospital, and it's not an AIDS hospital, mind you, are due to HIV. In Bangui, where we work in a hospital in Central African Republic, the HIV prevalence among adults is under 5%, and yet 84% of the deaths in hospital are due to HIV. So we have walking well, and then we have wheelbarrow. People who are brought, you remember WAFA in Lesotho, people who are brought to clinic in wheelbarrows. So, WHO, they just changed the definition of late presenters to anyone with CD4 under 200. Remember when we used to consider someone with CD4 201 to be healthy? So I would love to come back to you and show you data in terms of the high percentage of people that we are treating in West and Central Africa that started so sick. And unfortunately, we lose a majority of them. So in DRC, 1 out of 4 HIV positive inpatients died after admission. 39% of whom within 24 hours of admission. So if we know that 90/90 is feasible at the national level in countries that receive the proper level of support and where there's political will to scale up. So now we just need to make sure that the other neglected regions can also have that support and also be pushed to do the right thing and start scaling up treatment. So, UN member states, they signed the dotted line in terms of we're going to reach 30 million people by 2020. And now they need to move heaven and earth, essentially, to make it happen. I just want to share with you a bit of data, not from MSF, but Rochelle Walensky. Rochelle at the Harvard Group, so she published a report, an article last month, and essentially saying, okay, so South Africa, if they implement test and treat, here are the tremendous gains. But what if they miss it? So if South Africa misses 90/90/90 by 5 years, that essentially results, according to our modeling, in 500,000 new HIV infections and 500,000 new deaths. In 5 years, you lose 25 to 33% of the clinical benefits of treatment. So it's not only whether we're going to meet 90/90/90, we know it's possible, but also when. And so the impetus from this meeting is, given all of the science, it's a matter of how quickly as possible can we reach people as early as possible in their disease progression. And I will tell you, because this is 2016 and we were here in 2000, and the people that are not here that were HIV positive and took that stage, a little boy, a 12-year-old boy that was just waiting for someone that had enough power and guts to say, we need treatment scale up in South Africa. And the head of state of South Africa took the stage, shared the stage with Nkosi, and did not say that. Nkosi died within a year. Other people who were here in 2000 that didn't have access to treatment have died. And they went up on stage, they told their stories. So listen, there's an old activist adage, it's called, we honor the dead by fighting for the living. But frankly, it is 2016, and since we have the tools, we have the science, we know it's feasible, at this point we should be haunted by the dead until we treat every single person living with HIV. Thank you.
Thank you so much for that powerful speech. So we're going to now ask the journalists to come and ask questions. Can you make sure when you come up to the microphone, we got one there, so everyone can hear. Can you identify yourself and also say who you represent, please?
Hello, yes, Keith Alcorn from AIDS Map. This is a question for Maya Peterson. The design of your study was very interesting because you did the major community mobilization. I was just interested to find out, what do you attribute the great results that you've got? Is it the fact that you did the community mobilization? Is it the very tight linkage to care? What do you think is particularly responsible for the very strong performance in Cascade?
Thank you for that question. I think I'd like to start just by saying that we did see strong Cascade performance when you look at it one way, but we're still leaving a lot of people behind. So we achieved over 80% suppression in HIV positive. That means almost 20% are not yet suppressed, and so we still have work to do to figure out how to reach those people. I think it's also hard to say definitively at this point which parts of our intervention were responsible for the results that we're seeing. That said, I can tell you a little bit about what our communities tell us is working for them about this intervention package. Because again, the intervention for search really was aimed at optimizing all steps of the cascade. I think one theme that comes up a lot is the fact that we are truly a community-based, it's a community-based intervention, it's a community-based study. The communities have been involved with this study from the very beginning. In fact, the idea to provide HIV as integrated with other disease services really came from the communities. So maybe that's another aspect that makes our approach somewhat different. We integrate our HIV services with other multi-disease services. And our communities tell us that they really appreciate that it provides them with services they need, and it also serves to reduce HIV-related stigma. I think another thing that we hear a lot is making a big difference is that we have a very patient-centered focus on delivering care. And that starts at time of diagnosis, where there's a personal handoff of a newly diagnosed patient to the clinic where that patient will receive care. Sometimes called a warm handoff, but I think one of the providers I was speaking to last week in Kenya put it very eloquently. She said, what we do is we walk with the patient every step of the way along their journey. And I think that really captures that first step of establishing a relationship between the patient and the care system. We then continue that patient-centered approach to care throughout the care delivery system. So that includes really building a relationship of trust between the patients and providers, but also very concrete structural things that we do. So we provide flexibility in clinic hours, and that may seem like a very simple thing. I think it can be very powerful. So taking another story that I heard last week, there was a fisherman who was out all night on the lake fishing. He comes home in the morning and he needs to sleep during the day. So he sleeps during the day and wakes up in the afternoon, but at that point it's too late to make the regular clinic hours. So under our model of care, clinic hours are flexible. The providers arrange to meet him later in the afternoon when he's able to come. And by doing that, also begins to establish this relationship of trust. So this fisherman was then able to come to care. He suppressed his viral load and was able to discuss and see those suppressed results with his provider, which is highly motivating. And then the providers tell us that he's now going out to the community to tell other men that this is really a worthwhile system to be a part of. So I think that maybe encapsulates some of the aspects of the intervention that our communities tell us are effective. But again, I think we can't say definitively which parts are working at this time.
Michael Smith, MedPage Today. Question for Dr. Davis. It struck me that Dr. Pasniak sort of seemed to put your study and Dr. Peterson's study on all fours, but you were looking at a different thing. And I'm wondering, you saw that people went on treatment, and then you didn't see any difference in transmission rates or in incidence rates. But you don't know how well people adhered to ART through there. You don't know what their viral loads are. And so I'm not sure that, what can you actually say about the intervention in terms of preventing incidents if you don't know how infectious people were? Or do you, I guess is the question.
Thank you for the question, and I think I answered that, but you may have missed it. We have viral load data for those who are on treatment, and we achieve 95% viral suppression for all of those who accepted and entered treatment program and continue it during the study period. So it's 95% viral suppression, so that's optimal result you can get. There are two issues here. One is that not enough people linked to care and enter ART rapidly, and two, besides that, there are lots of in and out migrations, complex sexual networks that makes these communities not close communities, and therefore there are many other opportunities of transmission and therefore of prevention that the UTT alone cannot address. So we are certainly on the right track. We may have made less good results than what, for instance, Maya presented with the search study. Just to put also this into context, the study was conducted or started almost 2 years before before the other trials or other studies took place. So there are many information that have been obtained from other groups that we may not have fully integrated into the package. But the Africa Center where we work is heavily, indeed, very embedded in the population for many years, so community mobilization occurs as well. That's not sufficient in this kind of context, in this rural South Africa context, very heavily affected by the HIV, to obtain the uptake that we were expecting. But once people agreed to be treated, it worked very well.
Keith Alcom, AIDS Map again. Another question for Francois Dabi. You said that you were unable to reach around a quarter of the people in the households that you were approaching. Those were presumably the people who were either out at work or the migrants that you were talking about. Do you think that that was actually, even though they were a migrant population, but nevertheless that was the population that was driving the continued incidence in this study, that actually those were the people that had highest viral load in any case, whether they were on treatment or not?
Thank you. Yes, we, first of all, these are 25% of people that are considered by the information we get as residents. So they are not really people just traveling, they are people that are considered as residents. And even the context or the definition of migration is really context specific. So people migrate in and out for brief periods of time. And so that may be sufficient for them to be out when we get there. Although, as I said, we went there repeatedly. We went there even several times before going to the next house. So it's hard to get everybody by home testing. But on the positive side is that we got a lot of people, 75% again, who accepted, and most of them agreed to be tested. So what I'm saying is that home testing is another good way, a very excellent way, probably very cost effective. We will have to demonstrate that to reach people that otherwise would not come to HIV services. But we need to find other ways. We need to provide, camp. We need to provide, mobile services, mobile testing services on the top. One single approach to testing is not sufficient. But what I'm saying here is that home testing has been substantially increasing the proportion of people tested.
My name is Annalisa. I'm on East Coast Radio.
If you could try and get to the microphone, yeah, you have to do the high jump there, I'm sorry.
Hi everyone, my name is Annalisa from East Coast Radio. I have a couple of questions. The one is for Francois. With Eshowe and the dynamics of rural areas, did you guys find any evidence of drug resistance HIV? I know we've been talking a lot about other things. I haven't heard anything about drug resistance HIV, so I wanted to ask about that. And also, how long was the trial period for the research that was done?
So the first question on the resistance, we are starting to look at this at the moment. Similarly, we are also looking at what we call the phylogeny, which is the transmission of the strains between individuals. All these results which obviously will take time, but there is some resistance in this community, not at extraordinarily high levels, so it doesn't at the moment raise a signal that we are facing a specific problem, but we need to document it very properly and report it to you. So at the moment, the early information is that resistance does exist, but not at very high level. And the second question was on the length of the study. Yeah, the study took about 4 years to be completed, because we started by ask ourselves whether this was feasible and acceptable, and we so we worked in a few number of communities first, and we published this in a very important journal, PLOS Medicine, on August 9 of this year. Then we moved to other communities and finally closed the study just in June of this year.
Just a quick one, please, because we've got to start wrapping up. Thanks.
Okay, all right. So the other question, I think it slipped my mind now. Oh yes, with the home testing, in terms of the research, was it accompanied by counselling? And how often is this counselling? Is the counselling differentiated between adults and children with HIV?
I mean, really the home testing approach was really focusing on adults, and of course was surrounded by proper counseling. It's important to say that in this approach, we monitor very carefully whether we would have what I would call societal side effects, and we have not identified any or so little that I don't think that's an issue here. But otherwise, we really didn't focus on children in this particular program.
Okay, thank you all so much for coming to the press conference. You're most welcome, and we have to move on now to another press conference taking place. I'd like to thank all of our speakers and presenters here for being so succinct in giving you all the highlights of their data. This has been a live stream, but it's been archived if you want to go and look at it again at another time. Thank you again.